But if they were to run it for all the states, you can see that it would be even steeper, would run something like this. But the implication of this regression line is the more money we spend, the younger we die. And this, I think, is a principal or the principal cause of the problem. And that is that most of what we do in medicine has not passed the gold standard test of effectiveness and safety. The gold standard test is a randomized controlled trial. And when people have tried to catalog all the things that are done in medicine and figure out how many have actually been validated by randomized controlled trials, it's somewhere around 15 to 20% of all the things we do in medicine. That leaves 80% where we may be fooling ourselves. It's very likely that we're fooling ourselves about the effectiveness and the safety of those procedures. If history is any guide, and it's the only guide we have, we can expect that of that 80%, about half, if they were properly tested, would turn out to be ineffective. The problem is we don't know which half. We're clueless. Because of placebo effects, because of variation in illnesses, because of a variety of other confounds and figuring out whether something is working in a patient. We do not know whether things are working. We'll talk about some of those examples. But they're endless, basically. Well, here's a list of examples, sort of prominent examples. Bypass surgery was done for a period of about 10 years in anybody with a high-grade lesion in their arteries of the heart. High-grade lesion was a 70 or 80% blockage, depending on which hospital you were at. And did you get me some water? After about a decade, there were 3 clinical trials run, 3 randomized clinical trials run, one by the VA, one by the Europeans, and one by the National Institutes of Health. And it turned out that for patients with 1 or 2 vessel blockages, there was no decrease in the heart attack or death rate. Now, this was 85% of all the patients who were receiving bypass surgery. In the early days when we were doing bypass surgery, the mortality rate of the surgery itself was about 6%. So we were killing 6% of patients who never had any chance of benefiting from the procedure because we didn't know any better. We don't like to talk about this, but this is very common in surgery, that when a surgery is new, the mortality rate is high, and then it sort of drifts downward over a number of years as we get technically better at doing it. The current death rate for bypass surgery is about 1%. It's reserved for people who have 3 vessel or left main disease. It's definitely effective in people who have left main disease. It's sort of marginally effective in people who have 3 vessel disease. So it's a lot less common. In this country, we still do about 7 times as many bypass procedures as they do in Britain. For the people who didn't have these high-grade localized lesions in the left main area, the cardiologist invented angioplasty. Angioplasty is when they snake a wire up to your heart and open a balloon and crush the plaque against the walls of the artery. And for those people, they used to claim that they were preventing heart attacks. But when they finally got around to testing it, there was no decrease in heart attack or death rates. And in fact, there's now a placebo-controlled trial of angioplasty that finds no decrease in symptoms. So neither your symptoms nor your death rate is being decreased. Bone marrow transplant in late-stage breast cancer was done for a period of about a decade with the assumption that it was reducing death rates. When they finally tested it, there was no increase in survival. This is an extremely expensive procedure. It costs about $2.5 million over the life of a patient. It's a dangerous procedure. They basically wipe out your immune system and reinfuse cells that take root in your bone marrow to replace your naturally occurring immune system. Arthroscopy of the knee is done for painful arthritic knees. Turns out there's no improvement in pain or mobility compared to placebo treatment. They actually did 2 sham surgery studies in this for this procedure, and there was no effect on pain or mobility. Prostatectomies for men over age 65 have no increase in survival. They do decrease the metastatic rate, but there's no overall increase in survival. That's about 80% of the population that they do prostatectomies on. It's arguable whether these people are better off or worse off with the prostatectomies. There are, of course, complications of prostatectomies. Breaths in CPR, we did for 30 years, alternating breaths and chest compressions. When they finally tested just doing chest compressions, there was no increase in survival or cognitive outcomes. When you're not breathing, you can get brain damage. And so one of the outcomes they follow with patients who undergo these procedures is your cognition. Chronic albuterol in asthma was recommended for children with the thought that they would prevent status or asthma attacks. Turns out that the worst form of asthma attack, status asthmaticus, actually increases when you do this. There's sort of a rebound phenomenon that we didn't appreciate when we started this. They used to place idle IV lines in the ICU. The theory was they wanted quick access to your arteries to infuse medicine. If an emergency happened, they thought they would save lives this way. Turned out that the only thing it did was to increase infections in the ICU. PVC suppression in coronary artery disease. PVCs are preventricular contractions, a dysrhythmia of the heart that is associated with heart attacks. When they found a couple of drugs that could suppress PVCs, turned out they increased death rates. And this is sort of a common finding in medicine, that there are always unanticipated adverse effects of what we do. And we often are inadequately humble about anticipating them when we start with a new procedure or a new therapy. Fetal monitoring in cesareans actually increases maternal complications. In very few cases does it seem to make a difference for infants. Trans fats sold to prevent actually cause coronary heart disease, TBAs, cancer, and obesity. And there's a long list of these. The guy who's been most aggressive about pursuing them is this guy, Vijay Prasad. He's now at UC San Francisco. He's a young guy. He started this work when he was a resident at the Mayo Clinic. He's been absolutely a bulldog about chasing down examples of this sort of thing. And in his most recent paper, he found 325 different examples where medicine had adopted procedures. They were considered standard of care. When they were subsequently tested, they turned out to be ineffective or in some cases harmful. Another way to look at this is how well does your health system work? This could be longevity, but could also be your effectiveness at treating a variety of things like blood pressure or diabetes or complications of other sorts, strokes, and compare it to how much you spend. You can see that Britain, Australia, and New Zealand end up with the best performance relative to cost. If Ireland were on here, it would also be in this area too. The United States has both the highest spending and the worst performance on a variety of measures. Here's an example. This looks at years of life lost or days of life lost as a result of a variety of widely known illnesses. But for things like infant mortality, suicides, HIV infections, obesity, glucose levels, blood pressures, etc., we are worse than the comparable countries. They compare us here to 17 peer countries like Australia, Austria, Canada, Denmark, etc. But we're dead last in spite of spending almost twice as much as many of these countries. I don't know if you can see this chart well, but this looks at costs to the worker versus inflation costs. You can see that the workers barely kept up with inflation here. This pattern goes back to 1980 when Ronald Reagan was elected. And you would think, okay, well, the average worker is staying even, but that's misleading because inside the money that the average worker is making, healthcare costs are rising disproportionately. So that the average worker, the average working family is spending more and more of its income on healthcare, and therefore having less and less money for other things. Health insurance premiums have risen 213% over this period compared to 60% for income for the workers, and the workers' contribution to premiums has risen 242%. Over the last decade here, you can see that companies have started to back away on subsidizing healthcare. They're trying to pay less and less and putting more and more of the burden on workers. The Affordable Care Act has not had a major impact yet on health. The thought is it will have a long-term effect on diseases that take years to develop, like heart disease and stroke and cancer and that sort of thing. But it's only had a modest effect. It seems to have affected things like glucose control and blood pressure control and that sort of thing. And we expect longer-term benefits in terms of health. But where it has had a major, major impact is in bankruptcies for American families. So over the 10 years or so that it's been in existence, it's dropped the personal bankruptcy rate by half. A major, major solution for working families. If you look at life expectancy at birth, my voice is going. Life expectancy at birth, in general, it's risen. The last few years, it's actually gotten worse. On average, most of that has to do with folks who have less than a high school education. They've actually lost, on average, 4 years of life. There are a number of reasons for this. One of them is drug companies. Drug companies went through a period where they were pushing opiate drugs on doctors and saying they're not really dangerous. Addictions are low likelihood. Overdoses are a low likelihood. And you should give more and more and more to your patients who are in pain. And it turns out that when you do that, you quadruple the death rate from opioid overdoses. And what tends to happen, the natural history here is when doctors start to freak out about the amount of opiates they're giving, they cut the patient off and the patient turns to the street. So we've seen an absolute rise of about 3.5-fold for heroin overdoses at the same time. But these patients almost uniformly have started out with prescription opiates and have turned to the streets in order to cover their pain. The two companies that were sort of most egregious here were Incest, which is still in business, although they had to pay multiple billions of dollars in fines, and Purdue Pharma, which actually got sued by all 50 states and was put out of business, although the Purdue family walked away with, I think it was like $23 billion in their pockets from the company. Another issue here is if we have an aggressive healthcare system compared to the rest of the advanced economies, we expose patients to more medicines, more procedures, more diagnostic procedures, and we end up causing more medical errors. So a recent estimate is that about 250,000, this comes from the Johns Hopkins School of Public Health, it's sort of the premier school of public health in the country. They estimate that about 250,000 people die from medical errors. This actually may be a conservative estimate. There are published estimates that run as high as 400,000 a year. So it's not as much as cancer and heart disease, but it's a hefty chunk of deaths every year. So one of the things I've come to appreciate over the decades working in healthcare is that we look back at the period in the 1800s or even the early 1900s and think, oh, how backward they were. They did a lot of harm to patients, but in fact, you are probably almost as likely to be killed by modern medicine as they were by what the doctors were doing to them. To find humility in healthcare about the dangers that we impose on patients is not easy. You can find occasional examples of people saying, look, we can help some patients, but we can harm a lot. And we need to be awfully humble about what we're doing and awfully cautious about what we're doing. Gilbert Welch at Dartmouth refers to this as malignant iatrogenesis fulminans. Iatrogenesis refers to treatment caused, damage caused to patients by virtue of the treatments we impose. The Brits have always been more humble than us about what they do. In the old days, we used to refer to them as nihilists, that they didn't really believe in therapy. But they've always been more cautious about adopting procedures. So they do 1/7 the amount of bypass surgery. They do 1/10 the amount of back surgery. And they will typically learn from day one that they need to be cautious about what they do. I worked with a British cardiologist most of my career, and he used to say that when he had his heart attack, he was going to get a bottle of aspirin, a bottle of Jack Daniels, and go home because he was afraid they would kill him if he went into the hospital. Fox is also a Brit, and he reminds us that the fact that we can do something technically doesn't mean it's the right thing to do for a patient. What seems to pervade American medicine is a belief that if you understand normal biology and you have some degree of understanding of abnormal biology, you can come up with you can devise a therapy, and that therapy ought to work. And we don't need anything more than that to adopt a procedure. But in fact, the biomechanistic theory that we have almost always turn out to be incomplete and not total. And we end up with, again, inadvertent adverse outcomes. Or in the words of Artemis Ward, it ain't the things we don't know that hurt us, it's the things we do know that ain't so. Interestingly, Thomas Jefferson, a couple hundred years ago, perceived this problem in American healthcare. He wanted us to stick with sober facts and drop visionary theories. Another problem that is probably permitted by this lack of clear consensus about 80% of what we do is that the way doctors practice is very, very different from hospital to hospital, from state to state, and even from doctor to doctor. One of the things that surprised me when I first started working in healthcare was I was a trainee at that point, and I was rubbing elbows with the residents mostly. And they would tell me stories about how, you know, if one doctor was running a service, you would do things one way, and if another doctor came on the service to run it, you would do things the other way. And they would scream at you for doing it the way the doctor last had told you how to do it. So many of them, when the services were turning over their attendings, would stay up that night and switch things to the way the new doctor liked them, so they wouldn't get yelled at in the morning. But the result of that is that if you go across the country, you find wide variations in the way medicine is practiced, and it's reflected in the costs. So here we have a comparison of Salem, Oregon with Miami, Florida, which is the most expensive site in the country, of a more than a twofold cost in per capita Medicare spending. Here's a map that depicts the same sort of thing with about a twofold variation from Minneapolis to Manhattan. And you can see that the least costly areas are the upper Midwest, the Intermountain West, and the far Northwest. And the question is, do people out here live longer or live better than people down here in the darker areas? And the answer is no, they don't live longer. We know that for sure. If you track death rates, they do just as well, and in some cases may actually do better. If you believe that the market can solve healthcare problems, you're a fool. And this is an illustration of why. These are different healthcare corporations. Each of these dots is a hospital reflecting the amount of money spent on the last 2 years of life for patients. This is all Medicare comparisons because Medicare is universally available. And of course, what happens in a for-profit healthcare system is the people who bill the most and therefore do the most procedures are the people who get bonuses, and the people who bill the least get fired. And you have this sort of perverse incentive built into a for-profit healthcare system where doctors want to do more and more, or at least they're pressured to do more and more. The good ones know that they shouldn't do that, and they're much more conservative about the choices they make. But they get pressured by hospitals, they get pressured by group practices, whatever, to do more and more. This hospital up here is part of the Tenet Healthcare, or was part of the Tenet. They've changed their name. This was Republican majority leaders, Bill Frist's family's healthcare corporation. This hospital up here is Northern California Hospital. They got caught faking cath lab data in order to justify bypass surgeries and angioplasties. Over the course of the years that they did this, they probably killed a couple of dozen patients who really didn't need the procedures they were being given. There's actually a book written about this called Coronary by a guy named Klaidman, if you're interested in these kinds of examples. And it turned out that the surgeon and the cardiologist who were doing this, their punishment was 10 years of not being able to collect on Medicare. They basically had made so much money they both retired, but that was the worst punishment. I don't understand why they weren't prosecuted for negligent homicide. Screening is assumed to produce better outcomes for patients because you get diagnosis earlier. Is that really true? Or is it the case that we're imposing the knowledge of the illness and the cost and risk of the illness and treatment on people at an earlier stage in life when they'd be better off not knowing, frankly, when they have a mortal disease? There are a number of harms that go along with screening. For example, about 2% of cancers in the United States are thought to be caused by radiological procedures. They're mostly breast cancers because of mammographies done on a regular basis. There are occasional suicides. So when patients are given bad news as a result of screening, there are people who don't wait to get offered treatment or any other kind of support. They just go ahead and off themselves. Early identification of an untreatable illness with subsequent anxiety, cost, and risk. I once had a patient, I probably shouldn't tell you that story, but there are countries where they don't tell the patient the diagnosis of cancer, and they just allow them to live with the gradual decline. The family knows, but the patient won't know. The problem with false positives is that you get risk costs, unnecessary further workup or treatment, iatrogenic anxiety, depression, worry, and life decisions. And then false negatives can give you unrealistic reassurance. Probably the screening procedure that's been most studied is mammography for breast cancer. This is a study out of Sweden where they looked at if you ask 100 or let's say 500 women, whatever, what they believe about the effectiveness of mammography, and you ask them hypothetically, let's say we follow 1,000 women for 10 years of life, how many of them are going to die of breast cancer? The average answer is 16%, or 160 women will die over those 10 years of breast cancer. Okay, if you say to them, well, how about if we do screening every year or every other year in these women? They think it'll drop to about 8% or 80 women out of 1,000. The actual numbers are 5 and 4. And what that tells us is that this emphasis we have on screening procedures imposes a lot of anxiety on a lot of women that is not going to do anybody any good. Some people might say that one life is worth what we do to the other women, but 250 of those women will be given false positive reports and will be exposed to needle biopsies. A few of those will have minor complications of the needle biopsy. But it's clear that there's a price to be paid for doing all this screening. If you haven't read it, there's a very funny book called The House of God written by a guy about his internship year at Mount Sinai in New York. And his guru was a senior resident who he referred to as the fat man. But he says one of the observations he makes is it ain't easy to do nothing now that society is telling everyone that the body is fundamentally flawed and about to self-destruct. People are afraid they're on the verge of death all the time. Other screening procedures are for prostate cancer. You can see that as prostate cancer screening is going up and down, there's been maybe a slight decline. There's an argument about whether this is due to the screening or it's due to the new new chemotherapeutic agents. We really don't know that. We can't tell that from a study like this. Thyroid cancer, despite rises in the amount of screening that's done, no effect on deaths. Melanoma, screening increases, no effect on deaths. So we see over and over again that screening may do more harm than good. Another peculiarity of our system is that patients vary widely in how expensive they are to the system. So the most expensive 1% of the population use up about 25% of healthcare dollars. The most expensive 5% use up about 50% of healthcare dollars. And the most expensive quarter use up about 75% of healthcare dollars. So we have this subset of patients who are extremely expensive. And the assumption always made when you first show this to people is, well, that 1% are the really, really sick patients. That's not true. It turns out that about half of those patients are not highly sick patients, highly medically sick patients. What they are people who have sort of chronic medical ailments, but they have coexisting depression or anxiety, things that make their symptoms worse and make their ability to function worse. And instead of addressing that and treating that, which would do them more good, doctors, because of their sort of biomechanistic blindness, tend to pursue the next test or the next diagnosis or the next procedure. Let me switch to the next one. Okay, so stress and related behavioral problems are a major contributor here. This is a study we did back about a decade ago. We published about a decade ago. We were looking at all sorts of measures of emotional distress for coronary artery disease patients, and we were wondering which ones were associated with increased cost. When people had elevations in anxiety or phobic anxiety, their costs went up about 50%. So the question is, if we treat these people, do their costs go down? And I don't have a study that addresses that directly. I can tell you that their symptoms get better, even if their overall costs don't change. This is another study, also looks at a measure of anxiety and then looks at number of disability days, which quadruple the more severe your anxiety is. Number of physician visits doubles. Symptom-related difficulties, this is a measure we call ADLs, or activity of daily living, the ability to cope with the things you want to cope with in daily life. You know, do you stop doing things that are fun or enjoyable or meaningful to you? This is a measure, this is a study out of the Mayo Clinic also, looking at psychological distress as the strongest predictor of 6-month rehospitalization costs. Now, part of the problem we have is that the bias in medicine is not to think about these things until the last minute. It's not until they run out of things to look for that they begin to think, well, maybe it's stress. This is a study of nurses, residents, and attending senior doctors, comparing the Beck Depression Inventory with the nurses, residents, or attendings' sense of whether or not the patient has a psychological problem. And if they were good at this, what you would see is the cases would be clustered in the lower left or the upper right here. But what you see is a number of false negatives and a number of false positives. False negatives, false positives, false negatives, false positives. and this is the frustration people in my field have is how do we get the docs to pay attention to this stuff? They seem to be fairly obtuse about detecting it. This is a study we published about 6 years ago. We were interested in what predicts readmissions to our hospital. And what we found was far and away the strongest predictor was whether or not people had cognitive impairment. These are not people who had frank dementia. They had sort of mild versions of cognitive impairment in the mild to moderate range. None of them had been diagnosed as having cognitive impairment, or pardon me, only a small proportion, only about 10% had been recognized by their doctors as having a memory problem or cognitive problem. And even among the patients who had frank disorientation, which means they didn't know what month it was or year it was or what hospital they were in, they only recognized one as having a cognitive impairment according to their chart notes. So what you got is sort of patients bumbling through the system with their problems being unrecognized by the doctors. All this is not to say that medicine doesn't have successes. It clearly does. Probably the greatest single success are vaccines, which have reduced the burden of infectious illness dramatically and have saved untold millions, probably billions of lives over the decades. Other successes are the antibiotics, although they're becoming a problem now that we overuse them because we have this overly aggressive system. The Germans don't use antibiotics the way we use them. It's rare to find a patient outside a hospital who's prescribed an antibiotic in Germany. There are 4 meds that clearly have a major impact on vascular disease: heart attack risk and stroke risk. Childhood leukemia has been responsive to treatment. Diabetes, the invention of insulin, the discovery of insulin was a major accomplishment. The discovery of preeclampsia and how to treat preeclampsia in pregnant women has prevented many maternal deaths and infant deaths. The Surgeon General's report on smoking has had a major impact. It's dropped the smoking rate among men in the US from about 55 to 60% to about 15%, with the result that smoking-related diseases have dropped off dramatically. What you should notice about these successes, the vaccines as well as all of these, except maybe the treatment of childhood leukemia, is these are low-tech treatments. These are treatments that are done by primary care docs, not by specialty physicians. And that probably is a major problem we have in this country. We have far too many of our doctors are specialists. In Britain, the proportion of doctors who are primary care doctors is 80%. In the US, it's 30%. We have the lowest proportion of primary care docs in the country, in the world. And the bias of the specialist, of course, is when you have a hammer, everything in the world is a nail, and you're going to go out and find a way to use it. The result of these successes has been that we've dropped the childhood mortality dramatically since 1900 and shifted the overall death rate upwards. In 1900, the average age at death was 47. At present, the average age at death is 79. Clearly we've had some impact. There's a debate about how much of this shift has had to do with healthcare per se, as opposed to cleaner water sources, better sewage removal, less pollution in the air, that sort of thing. And some people think that the effect of healthcare on this shift may be as little as 10%. It may be a minor contributing factor. To give you a concrete example of what tends to happen in American healthcare, this is Henry Cotton. Henry Cotton was the superintendent of the Trenton State Mental Hospital back in the 1920s. He was a psychiatrist. He was trying to make psychiatrist into a scientific discipline. And he convinced himself that the crazy patients he had in his institution, these institutions don't really exist much anymore, but in those days, they consisted of thousands of patients, most of whom had psychiatric disorders, but many of whom were dementing, some were retarded, autism, probably ended up in these institutions back then. Severe depression, dementia secondary to substance abuse, particularly alcohol abuse, was probably pretty common. But Cotton got it into his head that what caused these major mental disorders they were seeing in their hospitals were infections. And that was not an unreasonable guess, because infections can cause you to become confused and hallucinate. There's a condition called delirium, which is very common in inpatient hospital settings, that to a layman or an unsophisticated internist might be interpreted as schizophrenia, unless you know what to look for and know how to take a history properly and know how to rule out those kinds of problems. I spent most of my career working on inpatient medical settings, and roughly half of the patients we saw were patients who were referred for either depression or schizophrenia, who in fact were delirious. So we would constantly have to walk in and get the doctors to look for other sources or causes of the confusion. But infections was a fairly common one. Cotton decided he was going to cure these people of what he thought were focal infections somewhere in the body. And he started with teeth. He decided to hire a bunch of dentists, and he would bring these dentists in and pull all the teeth out of the crazy patients in an attempt to cure them. And he managed to convince himself that he was curing people, which is, it's interesting to ask why he was convinced. And it was probably due to the fact that people were in post-op pain, or they were on post-op analgesics, or they had post-op blood loss. And that so for a period of time after the procedure, they probably were quieter than they had been before the procedure. But he did this for about 20, 25 years in Trenton, and he convinced a lot of other psychiatrists around the country that they should be doing it too. And then a group in Massachusetts did a randomized controlled trial and said, we can't find any evidence of any change in these patients. Cotton went to his mentor, who was Adolph Meyer, probably the premier psychiatrist in the country at that point, who was at Hopkins as chair, and said, well, you know, I need help. You need to send me some students so we can demonstrate this effect. They sent him a student. He did a follow-up. The student did a follow-up on several hundred patients, said, I can't find any evidence that these patients are any better. Cotton blew his cork and screamed at her and accused her of incompetence and all sorts of things. The study was never published. It was buried. It ended up in the files of the Welch Library at Johns Hopkins. It's still there. And he went on his merry way and continued doing what he was doing. It wasn't until the drugs became available for major mental illness that we began to see a turnaround, and the diagnostic procedures in psychiatry got better, that we began to rule out certain things and keep people out of those hospitals. The important thing to understand about Cotton is he wasn't making this up. He was a true believer. He actually had his own teeth pulled. He had his wife's teeth pulled. He had his kids' teeth pulled to prevent mental illness. It didn't work very well. When he was being challenged by these other doctors, he got very depressed and spent about 8 months in an asylum out in Colorado for a rest cure. One of his sons committed suicide. So pulling your teeth doesn't seem to help with mental illness, in case anybody ever asks you if you want to have your teeth pulled. Another example is Ignaz Semmelweis. Semmelweis was a student from Budapest who was sent to the capital of the Austro-Hungarian Empire, which was Vienna. He was supposed to go and learn the law, but when he got there, he ran into a bunch of medical students, and they went out drinking, and he passed out in a room his first night at school, and they dragged him off to lecture with him the next morning, which turned out to be a dissection of a cadaver. Well, he was fascinated by all that, changed his course of study, became a medical student, rose through the ranks, eventually took what today we would call an internship at the Berlin Lying-In Hospital. Berlin Lying-In Hospital was this huge obstetrical hospital. It's 500 beds, and it was free. for the mothers of Vienna who were delivering, and it was supposed to bring modern medical care to the mothers. There was one ward set aside for the daughters of the rich who had gotten pregnant out of wedlock, but the rest of the hospital was open to students as part of the learning experience. Semmelweis was in charge of one ward. He was like a lot of his compatriots. He was puzzled by the high rate of death from a condition called puerperal fever, or childbed fever, which was basically a rip-roaring peritonitis. It was an infection of the abdominal cavity, and it would happen in these mothers, and a significant chunk of them would die. In some hospitals, some months, the death rate was as high as 30%. What happened while he was there was the director of the hospital divided the services so that one service, they used to be trained together, but one service was going to be run by midwives, and one service would be run by the medical students. And very quickly it became apparent that the death rate on the service being run by the medical students was about 3 or 4 times higher than the death rate on the service being run by the midwives. And everybody said, well, that's because there's a miasma over the wing of the hospital where the medical students practice. Miasma is like a bad airs. And he was puzzled by this, as a lot of people were. But what really sort of caused him to start thinking differently was one of his mentors developed cadaveric fever. Cadaveric fever was caused by slicing your finger while you were working on a cadaver. And you would develop, again, this rip-roaring peritonitis and croak. And there were a number of staff who'd had this happen. And he read through the postmortems and he said, you know, this looks like childbed fever. It looks like puerperal fever. It's the same thing, except it's happening in males rather than females. And he showed this to his professors, and they said, oh, you silly boy, everybody knows that puerperal fever is caused by miasmas. And he thought and thought and thought about this. He was heartbroken about losing his mentor. And he began to wonder if cadavers somehow had something in them that was causing this infection. And so he began to require the nurses, with much resistance, by the way, the nurses and the staff on his ward to wash their hands. And he was able to drive down the death rate by about 80% by doing that, although he had to fight like hell to get the staff to cooperate. He took his data to the professors, and the professor said, oh, you silly boy, everybody knows that cadaveric or puerperal fever is caused by miasmas. And so he got control of 2 different wards and did what today we call a counterbalance design. He washed hands 1 month on one ward and another month on another ward, and could demonstrate that he could switch the death rates at will. And again, the professors didn't want to hear it. They said, well, you know, it must have been in miasma over the east wing of the hospital and not the west wing, or the west wing the next month and not the east wing. But you can see that the process here, the psychology here, is that the professors have a pre-existing belief they're not going to let go of. And you can understand why. First of all, it would be embarrassing, and secondly, it would induce an enormous amount of guilt for them to accept that they were killing patients. It wasn't until 50 years later that germ theory became accepted. And once germ theory was understood, then somebody said, oh, that's why Semmelweis was able to do this. He got it right. And we didn't know that. Semmelweis himself gave up in Vienna and went back to Budapest and taught several generations of Hungarian doctors how to wash their hands. That probably saved a lot of lives. He's buried in this patio in Budapest, in the courtyard of the house where he was born and where he died. There's a story told that when a paper finally came out and said, oh, well, you know, we all know puerperal fever is caused. This is when he was up in his 60s, I think. We all know purple fever is caused by miasma. He committed suicide. He actually didn't. He had some kind of dementing illness and ended up dying in a psychiatric hospital. The guy I was talking about earlier, the student from the Mayo Clinic, had, among his reviews of those procedures, which have turned out to not be effective, has noted that most of them were adopted because of what he calls pathophysiological concepts. I've taken to referring to it to biomechanistic theory, the belief that we understand what causes these illnesses and therefore we can devise cures. So I think the lesson today is, William Osler once said, it's much more important to know what sort of patient has a disease than to know what sort of disease patient has. Arnie Anderson was one of my mentors at Hopkins, and he was very fond when people would come through and huff and puff and be all excited about some mechanistic thing they were able to demonstrate. He would say, well, have you done a clinical trial yet? You know, when you've done the clinical trial, come back and see us. But he would invariably get up at the end of somebody's grand rounds presentation, remind them that in God we trust, but everybody else has to show us data. And of course, Winston Churchill was fond of pointing out that you can count on Americans to do the right things, but only after they tried everything else. And the question is, when will we get to Medicare for all, when we can probably start to fix some of these problems? Thank you for your attention. Anybody got questions?
I have a question. The high cost of medical care in Miami, could that be attributed to the average age of the population in Miami?
No. That cost is cost per capita. It's not cost for the overall population. It's the amount we spend on an individual per year on Medicare, or yeah, I think that was per year of Medicare billing. So it's corrected for the population aging.
I have a question. I wonder, I looked at the dates on a lot of your charts, which has changed. Some of your information is 15, 20 years old. Do you see the same trend even now? What's changed?
Well, there's a body of people who are more vociferous about the need for clinical trials. You can see this playing out right now in front of us around the vaccine. You know, Trump and the Republicans want a vaccine tomorrow, and Fauci and the scientists are saying, look, we need to know whether we're doing harm with this vaccine before we give it to a whole bunch of people. And it's going to take us some months of administering it and then waiting to see who gets the disease and who doesn't, and who dies and who doesn't. So that dynamic is there. But there's a cadre of people. Don Berwick is one. The Cochrane Collaboration is another organization that's a British organization that advocates for clinical trials, and more clinical trials. So there's sort of a shift taking place, but because of the financial realities in the American healthcare system, the doctor loses money if he practices conservative care. So he's under pressure to pay his overhead and pay his medical school loans. And the shift that has to take place is somehow we have to devise a system where doctors and hospitals are paid for doing the right thing rather than being paid for doing the most expensive thing.
Yeah, I got a question again about follow on to Miami. I don't understand why Miami's got a very old population on average compared to, say, Boulder or Eugene. So even per capita, wouldn't the age skew the data and cause it to be more expensive?
The answer is, if you're asking me, is the overall healthcare costs in Miami or in Florida higher? The answer is yes, but that's not what that data was presenting. What that data was presenting was cost per year of life. So they're comparing 65-year-old and older people in Miami with 65-year-old and older people in Oregon. You follow me?
Yeah, okay, now I understand. Another question. On one of your charts, you said there were like four drugs that really helped cardiovascular.
Yes.
Can you name them?
Yeah, aspirin, beta blockers, statins, and ACE inhibitors. Those four medications, each of them, aspirin lowers the risk of a heart attack about 40%. The statins, the ACE inhibitors, and the beta blockers lower the risk about 30 to 35%. So when you add those four medications to regular exercise, not smoking, and not doing cocaine, you dramatically increase the likelihood that you're not going to have a heart attack or a stroke.
Thank you. I got to start.
Yeah, it matters. It's important to take it the right way, by the way. You take it with food.
Hi, Mark. Dave Crowder from Boulder here. So you mentioned a couple of screenings that were, not really seemingly effective. But I wanted to ask about the effectiveness, really, of colonoscopies.
Good question. Colonoscopies, it's unclear at this point whether they save a lot of years of life, because what tends to happen is people who have positive colonoscopies tend to have them later in life. You don't get a positive colonoscopy in your 20s or 30s or 40s. You get it in your 60s or 70s or 80s. So many people who get a positive colonoscopy end up dying of something else long before they die of the colon cancer. Now, with colonoscopies, you get, they're looking for these growths in your colon. And many people have these growths, but most of the growths, only about 1% of the growths are actually cancerous. Most of them are benign. I've never had a colonoscopy, and I never will.
Mark?
Yeah.
Thank you very much for your lecture. That was really great. It was kind of sobering. My question to you is, what's your take on why the United States is so hesitant in having preventive measures? So I was born and raised in Germany, and there was always the point of health education. And if you had something, they were trying to treat it with, well, for a lack of better word, a spa treatment. So you would be prescribed to go there for 6 weeks, relearn habits on how to eat, how to exercise, how to just have a different lifestyle, and have other treatments that over here, people, when I talk about it, laugh at me.
Yeah, well, that's an interesting question, because in Germany, the health system evolved out of the rule of Bismarck. And it was conceived as a way of trying to unify the German peoples into a single country. So everybody got the benefit, and they were not uncomfortable with a socialized healthcare system from the beginning. In this country, healthcare evolved as sort of a cottage industry. It was a small, really until World War II, it was sort of a small businessman shop. Most private practitioners practiced alone or in small practices with other doctors. And unfortunately, they were contaminated by free market madness and resisted any kind of preventive work. Over time, the AMA and the specialty societies have been able to convince the insurers and Medicare and that sort of thing to pay for higher and higher tech procedures without any accountability for whether those procedures save money. So those things that really matter a lot in the long run for your health, which definitely includes things like exercise and smoking, and probably stress management, and that sort of thing, have been seen as sort of not real science, or not important science, or something that the nurses should be doing rather than the doctors. And so it's been left out. But Germany is still that way. They will still pay for your stays and treatments and that sort of thing. They're an interesting country from a healthcare perspective. They pay their doctors substantially less, but they also don't impose the enormous medical school costs on them that we impose on them. I have a friend in Germany who was originally trained as a cardiologist, couldn't make a living at it. And he ended up practicing psychosomatic medicine, which in Germany, for some reason, is totally separate from psychiatry, which is unthinkable in this country. So there are cultural issues here that matter. And, doing the kinds of things that we think of as preventive could probably make a large difference. Certainly, getting people to not drink excessively, getting people not to smoke, getting people to exercise, those are all unquestionably beneficial. They help prevent dementia, they help prevent heart disease, they help prevent cancer. All those things are enormously important.
Thank you.
Mark, I appreciate your comments. Have you had a chance to be called, or the opportunity to be called, for congressional testimony in Washington?
No, I would love to take a shot at that. I'm not sure I could keep my mouth well enough controlled to not get in trouble. But there are other people who occasionally are called up. They rarely are aggressive about pointing out the limitations of our high-tech healthcare. Don Berwick is one. He was proposed to be head of HHS. The Republicans got in his way. They stopped him because the drug companies didn't want him, and the device companies didn't want him.
The data is so convincing, it's really sad.
Yeah. Politics matters.
Do you have suggestions for solutions, or how this can change? We just turned the light off, so I'm in the dark because my grandson's going to sleep behind me. But what are solutions? I mean, I've been working in healthcare for many, many years, and I see what you're talking about because I've seen it in person. And it's very frustrating, but I wonder what you're suggesting needs to be done.
I don't have an easy answer. I think things like this COVID crisis are forcing people to ask, do we have a healthcare system that can work?
Right.
And the answer is, unless Trump had actually imposed the Defense Act and said, I'm taking over, and we're going to provide PPE wherever it's needed, and we're going to provide
Right. And
drugs wherever they're needed, and to hell with you people who are here to make money. As a result, the states have ended up paying like 6 times as much for these things, which is absolutely crazy. Just the overhead alone in our healthcare system probably costs us, well, the British estimated $435 billion, because you've got armies of bureaucrats who are hired by the insurance companies to resist paying. And you've got armies of bureaucrats who are hired by the hospitals and the doctor's offices to get paid. And they spend hours fighting with each other over bills. When Clinton was trying to reform the healthcare system, there was a comparison made between a 600-bed hospital in Seattle and a 600-bed hospital in Vancouver. And it turned out that the hospital in Seattle had 300 people devoted to billing. That's all they did all day long, was billing. In Vancouver, it was 6 people. And they interviewed the guy who headed the hospital in Vancouver, and he said, if we didn't have Americans coming to Vancouver, we could get away with 3 people. But The Canadian health system is so simple that it's just a matter of punching a few buttons and that patient's done.
Okay, do you think universal health care will, if it really becomes the way it is here, will make a change?
I don't see how we can avoid it. You know, the Medicare system is immensely popular. Nobody wants to screw with it. And it's the third rail in politics. It's death for politicians that try and screw with it. And sooner or later, somebody's going to come along. And it might actually be Biden. Biden's been having discussions with Bernie about this. They might actually turn around, instead of saying you have to join Medicare, they might turn around to the employed people who say they're happy with their health care. By the way, everybody's happy with their health care until they get really sick. And then when they try to dump you, you're not happy anymore.
All right.
Thanks. But the rumors I'm hearing is that they might offer to say, okay, you can keep your employer health care, or if you want, you can now get Medicare, and your employer has to pay us the money they're paying to your health insurance company, which would be a gradual turnover. If you remember the history of the Affordable Care Act, everybody hated it at the beginning, or a lot of people hated it at the beginning, and within about 5 or 6 years, everybody loved it. Nobody wanted to get rid of it. And
Except the president.
Yeah, except our current
Yeah.
president.
Because our son had it and lost it. And that's his health care, and now he has none. And
How did he lose it?
well, because he was working independently for himself, and they wanted all kinds of records from him, and which he couldn't produce. He was an independent contractor. And in the end, they said, well, you have to provide us with these records or you're not covered.
What records were they looking for?
Well, he had to prove income was low enough to qualify.
Oh, okay.
And his income varied so much from time to time. So they're not giving him health care. Universal health care doesn't seem to apply across the board.
Yeah. Yeah, so his eligibility was an issue.
Yeah.
Yeah, I see. Okay.
Hey, Mark,
Yeah.
I think we're going to probably have to wrap it up. Do you have any
Okay.
final words?
No?
Well, I think that was really interesting. I think that this was very useful for this audience, and I learned a lot from this. I'm never going to the doctor again.
Thank you.
Thanks a
very much.
lot,
surprised I
because
didn't hear
I'm
from
having
David
surgery next week.
on this
And
one, but
it's going to keep
he's
me
all thumbs up.
wide
So,
awake.
want to remind everybody that if you have a talk that you'd like to give or that you've given in the past, or you have a subject that you'd like us to pursue, let me know, or let John Miller know, or John Wiltsey, and we'll see if we can get somebody.
And don't forget that
I haven't heard from a woman yet, so I know someone who knows a lot about airplanes, but he probably speaks with a German accent.
Okay.
Might be a problem.
Hey, Bruce, let's
Anyway,
remind people
Thank you
that
very much, and look forward to seeing you next week. Thank you very much.
Hey, Bruce,
Bye-bye.
let's
Bruce, why don't you let Ed give a preview of his